Hi, this is Long. Welcome to our video series on search patterns for the most common studies in radiology. Please note that this is an introduction to study interpretation. An enormous amount of detail is omitted for brevity. Continue dedicated reading, seeing as many cases as possible, and keep getting feedback from subspecialists during the course of your training.
All right, so today we're going to talk about a basic approach to the pediatric contrast enema. This is a study that's done in a few scenarios. The most common, or the one that people generally think of, is in a neonate when you're concerned about distal intestinal obstruction. So the classic differential here applies. People are thinking about Hirschsprung's disease, functional immaturity of the colon, or also called small left colon, meconium ileus, and then uncommonly like an ileal atresia. Sometimes these sorts of exams are done in slightly older patients. If there was, a necrotizing enterocolitis and you're looking for strictures, or even older patients if you're looking for like a late onset Hirschsprung's disease. This video is going to focus on the first of these circumstances in looking for distal obstruction or functional obstruction in the intestine in neonates. All right, so big picture. How are we going to look at this exam? So the overall structure is, as with all studies, you want to get a sense as to what's going on with the patient. What is the birth history? What are, maternal comorbidities that may increase your suspicion for any of these entities? Look at the current age of the patient, the gestational, prior gestational age. Look at prior imaging to know, get a sense as to the, if you have a sense of the bowel anatomy, any support devices and things like this. And then we're going to look, when you're actually in the room, you want to kind of examine the patient yourself and look for rectal malformations or anything that's going to kind of impact how you do the exam. And then, if you're very concerned, if there's a significantly high concern based on the clinical history, based on the presentation of active inflammation or an enterocolitis, you may want to delay the exam, because instilling that contrast or performing this exam can increase the risk of perforation and sepsis. Okay, so here we have what a typical study can look like. I'll just go through the images very quickly, and then we'll start again from the beginning. And I have to say that here we're going to talk a little bit about the procedure of how to do it. But with just the image, we'll kind of just just touch on the major points, as it's kind of best to actually be in a room and kind of learn about how to manage the logistics of actually performing the study. So I'll just touch on the major points here before we go through the actual imaging. So major considerations are that you're going to want a water-soluble, non-ionic contrast, diluted enough, usually about 50%, so that when it's instilled into the colon, you can see overlapping loops. You can kind of see through the contrast a little bit. We have here kind of a first image. As with all pediatric patients and use of fluoroscopy, you're going to want to use the last image hold as much as possible to reduce radiation exposure, and then kind of cone, and additionally cone down as able. As you can see in this particular study, we already seeing a couple things just on this image. You see the whole anatomy, some of the upper extremities, lower chest, etc. You see that the patient has an umbilical venous catheter. You see an enteric tube projecting with tip near the stomach. You've got we've got some density up here, which if you were to do your homework on this patient, you'd learn is some retained contrast in the stomach. But this is kind of our starting point. So just again to look around and see what is going on. A key thing as you're looking back into prior studies and then also on your first preliminary look at the abdomen is if there's any concern for like new or recent free air, periportal venous gas, pneumatosis, any sort of thing that can make you think that there's active bowel inflammation, or neck, things like this, you want to reconsider actually performing the exam. So things like, those sorts of things are what should be on your mind as you're leading up to the actual procedure, actually performing the study. So as you get ready to start the exam, so this is kind of like the last image, but let's go to where the beginning of the study is. So here we've are this in this on this first image that's taken here, the patient has already been catheterized. So the first step, even before we obtain this, is catheterizing the rectum. So you would do so with just, again, big points to get you familiar with what it is, but it's really important to have that kind of in the room instruction is you're going to be catheterizing with a Foley catheter. You don't want to inflate the balloon. And then to help maintain that seal, you can use some tape. You can put like a diaper or some other something below the patient to contain any leakages. And then, as you'll see, as is demonstrated here, usually with the patient in a left or right lateral decubitus position, you'll have you'll slowly instill contrast, and you want to make sure that you're having the expected distribution retrograde into the colon, and you want to keep an eye out for any evidence of mass effect or extrinsic compression that could also explain the distal obstructive symptoms. It's not common, but it's something to look for. And then as you continue to go up and you see that there's movement of contrast beyond the rectum into the sigmoid, you can turn the patient, and as you see after a couple images here, we're going to have kind of supine imaging. All right, and we're going to continue with that slow imaging until the contrast goes all the way up, and then goes through the sigmoid and all the way up to the proximal aspects of the colon, if possible, refluxing into the distal small bowel. Okay, so let's go all the way through. Perfect, right? So this will be kind of like the last image we have here, and it will be the same or very similar to the last kind of saved summative images that we have that we showed at the beginning of the study. So let's go all the way to the end again. And so in terms of evaluating the imaging findings for the pathologies of interest, the sort of questions you want to ask yourself are, what is the rectosigmoid ratio? You typically expect the rectum to be larger in caliber than the sigmoid, so like a rectosigmoid ratio greater than 1. Inversion of that ratio is going to make you think about Hirschsprung's. You can also look, especially as, and you can do this on the dynamic images, is are you seeing, any kind of sawtooth appearance of the bowel wall, as you've been instilling, and you're reviewing the images, and then you're kind of looking at the summative and like end images. Is there a point where there's any holdup of contrast or any apparent luminal stenosis? Is there a transition as you're instilling contrast, as you're going through from normal caliber to smaller caliber, particularly in the region of the splenic flexure, as you would expect with like small left colon syndrome. Are there other areas of change in caliber? If you take a look at the overall morphology of the bowel, does it at all seem like the entire colon is small? So not just changes in caliber focally, but diffusely. The classic differential in that case is going to be like ileoatresia or meconium ileus, total, rare total colonic Hirschsprung's, or again, all very rare megacystitis microcolon intestinal hypoperistalsis syndrome. And then if there is, if you can see, and I don't think that we see very clearly here, is there any reflux of contrast into the small bowel? Are we seeing any evidence that these bowel loops, as seeing in real time, are going through any sort of hernias or an inguinal hernia, things like this? Again, particularly uncommon entities. But those are the sorts of questions that you're going to want to ask yourself, basically on each of these studies. If you as you're going through the study, you want to make sure, at the end, as we do for all imaging, to at least remember to take, to eyeball the remaining anatomy to see, especially if the patient has not had prior imaging of various parts of like the lower chest, the abdominal anatomy, just to make sure that we're not going through by something very obvious and incidental. And it's important to keep in mind that this sort of exam, or the contrast, or the barium enema, you can't really completely exclude Hirschsprung's. Though if you do see these findings, it suggests a diagnosis. The gold standard, at least at the time of this video making, is, again, biopsy. And then you want to kind of consider if there's, if the patient as a whole, especially if the patient had new symptoms and they're, had recent change in feeding patterns, if there's some sort of allergic colitis or anything like that might be going on, right? So just, again, keeping these things in mind to put together everything you're finding on the study with the clinical picture as best as you can. Okay, so just as a quick recap, all right, the pediatric contrast enema is, a lot of it is in understanding what's going on with the patient and then the procedure itself. We kind of touched on some of the highlights of how to get that started and instill the contrast, and being sure to look for all the potential abnormalities you may see that could explain distal obstruction. Obviously, usually like imperforate anuses or things like that. Anatomic abnormalities are going to be apparent clinically before the patient even reaches you. But to take a look at that and take a look at any extrinsic or intrinsic bowel abnormalities as you instill the contrast, and just keep an eye out for any other incidentals, and just understanding, the role of this sort of exam in the potential diagnosis or of suggesting etiology such as Hirschsprung's disease.